Ready?
Okay. Ready.
Okay. Hi, I'm Dr. Mark Darner, board certified chiropractic neurologist. Today we're going to talk about flexor dominance and what occurs as the body is aging and what's happening with the brain with aging. So here's the brain stem, then we have the cerebellum here. And here in the parietal cortex, the brain has a map. And that map determines posture and tone of the body. And then we have ocular cueing that can associate with the frontal eye tracking field, interface with the parietal body map that goes through the cerebellum, up through the inferior olive, which is the autonomic regulator of muscle tone. So the inferior olive implements the program which is given to it up here by the parietal cortex. So what happens with head injury or chronic positional occupational, people that have jobs where they're bending forward, blows to the head, heavy dental anesthesia, surgical anesthesia, the parietal lobe can become dysregulated where the brain starts to think you're doing something different. And when it perceives that there's a difference here that needs to be adapted or overcome, then we have a survival program that's initiated by the parietal cortex that's inappropriate, and then we get inappropriate forward head weight bearing, dysregulation of posture, pretty typical aging effect also, this flexor dominance posture, forward head weight bearing, pretty common to see people in this position as they age. So how do we intercede on this and reset the parietal cortex? Think of this as the software program that's implemented through the manager, which is the cerebellum, and then implemented by the assistant manager directly to the workers, which are the muscles. So if we have this situation where the most common one is the brain perceives we're falling back, and it's going to reflexogenically push everything forward and into an anterior inappropriate driven position. Well, we can intercede on that using optical kinetics. Optical kinetics, in eye movement, we have a fast phase, which is termed the saccadic portion of the eye movement, that moves slow phase, which is the pursuit. So the pursuit eye phase is when you're tracking something, and the saccadic eye movement is the quick snap to a target that's coming at you. Somebody's throwing a ball and you need to move your head, or you see the dog or lion is attacking. I've got to turn and run. I need my eyes to go that way as I'm running, and that bypasses the frontal lobe because it needs to be a very hyper-fast reflex for survival. So we can use that hyper-fast reflex or saccadic eye movement with optical kinetics to stimulate the frontal accessory eye field, That's going to influence the parietal cortex, and depending which way we snap or saccade the eyes, it has an influence on reprogramming this. So when the brain perceives you're falling back, we need to have an upward saccadic eye movement, and that cues the brain that we need to be in a forward. It's not in a falling back position, it's more forward, and it changes the center mass of the body. If it looks rotational and the brain perceives we're in rotation, then we have a left or right saccadic eye movement to cue back to a normal center mass. So when the patient presents and they're forward weight bearing, hamstrings are tight, back is tight, neck is tight, or we get this translation effect of the cervical spine and straightening, we need an upward saccadic eye movement, frontal accessory eye field, resets that forward movement back to and cues the brain that we're not pro-survival with this weird body position. That comes down through the cerebellum and is implemented at the inferior olive to correct posture back to something standard. So we're using optical kinetics in the office today. If you have more questions, feel free to call us at mynewspine.com. Have a great day.